Let's go.
All right, thanks for your patience with the technical issues that we're having on this. All right, so this morning it's the rise of workplace violence, addressing healthcare's greatest threat, driving transformation change in healthcare. Let me tell you a little bit about how this got started. First of all, Eric did a research project for the Institute for Homeland Security at Sam Houston State. And this was the title of the research project that he led a team on. And it has now been published. It is on our website, and we can make the presentation available to all of you, or his research project is available to all of you for free. So let us know if you're interested in that, and we can point you to the right link so that you can download Eric's research. And then after the research, Eric spoke at the ASIS, the IHSS conference in Peru, and he redid this same presentation that he did for his research down there. We're going to be using his PowerPoint from that particular session. As you can see there, it's a smiling face in Peru at that particular conference. And we're not going to retranslate this for you. You know who Eric is. So Dennis, take us away for
John, I have to apologize, John. I'm trying to follow you here. I do not see the PowerPoint presentation. If everyone else is, I'm unable to see that at this point.
Does everybody else see it?
Dennis, we can see it.
Just bring up the one on your desktop.
Hey, Dennis, if you want to just come to my office and present from here.
All right, so let me take this first.
Yeah, I'll be right there, Katrina.
Okay.
All right, so while they're doing that, let's continue on this one. The Healthcare Crime Survey from the association reported assault rates against healthcare workers increased from 9.3 in 16 to 11. The 21 report, assaults against healthcare workers post-pandemic reached an all-time high in this. How does this reverberate, first of all, with all of you? Does this sound right? Do these figures resonate with you from your facilities? All right, we'll move on to the next one here then.
Yeah.
Sources of violence. Number one, patient to staff. Most prevalent source is patient-employee violence, in which a patient displays aggressive behavior towards a healthcare worker, such as verbal abuse, physical, and sexual harassment. Number two would be colleagues, conflicts between employees, intruders, and then family members. Would anybody care to comment on those?
Yeah, this is Shane at Texas Children's. We actually have the same number one, but our family visitors are number two most, I guess, violent situations that we go to, because they're usually escalated due to the type of situation that they're in, as well as interfering with care.
Anybody else care to share?
Yeah, I'd have to agree. At Chris's help, I think number two is family for us. I don't think I know it's number two for us.
I was wondering about that one. That seems to be what I have found from going from different place to different place, different systems. So, what about colleagues? What about internal? Where should that be placed? Is that if that's not a number two, where would we put colleagues?
I think colleagues for most of us, is probably 4. We have more issues with families and domestic more so than colleagues.
Yeah, we're seeing at TCH escalation between colleagues, but it's definitely 1 from patients, 2 from families, 3 from colleagues, and then 4 would be kind of like domestic violence situations or outside person coming in, which would be like type 1 under OSHA definition.
Let me ask you, if from patient to staff and then family, does that bleed over to colleague to colleague?
No, not necessarily. Most of the conflicts that we're finding are personality conflicts or supervision conflicts from staff to staff.
Okay. So if it's patient to staff and family, what's the biggest agitator? What's the thing that sets it off from what you guys are saying?
Gaps in communication.
I would agree with that because what we find is a lot of people like to Google the symptoms and think that they know more than the staff that's caring for the patient, and that creates a conflict right there where they're not communicating what the care is or the plan of care is or involving them in the explanation. They just come in, do their work, and then leave.
A lot of pressure to get in and out though out of the rooms though, isn't there? Because there's so many beds to take care of. How often do you guys get called? How often does security get called into the room? Is that increasing?
I would say it is for a lot of your acute care hospitals, because the clinical staff have reached the point where they don't want to have that uncomfortable conversation with the visitors or the family, explaining to them certain things that the visitors and the family want to know. So that's the security as the mediator, communicator, and the ones who are explaining to them what the clinical staff probably could have, but just reached that point of agitation to where they don't want to do it anymore.
Do you get called more by nurses or doctors to help?
I think it's more nursing, definitely more nursing calling security now. And I'll agree with the previous justification, but I also think too, we're educating clinical staff to be more aware of the signs and to bring us in earlier before there's an actual event happening. So there could be that component as well.
So when you come in, do you feel like you're prepared to read the situation right?
I will tell you,
really varies.
I will tell you, those officers who are really good at de-escalation and follow the recipe around that are much better than those officers who come in and just blindly follow the instructions of clinical. Because I've seen, since we've launched our Body Worn Camera program, some of our officers tend to, they want to act like they're the enforcers, like, clinical has told you to do something, you need to do it now. And they rush in with that mentality. But those who come in and say, what's happening? Let me ask you some questions. What's going on? How do we solve this? People who know how to de-escalate and talk have a lot less issues than somebody walking in saying, okay, if you don't do what I tell you to do, there's going to be a problem. And that instantly just throws the situation off the register. So.
Yeah, that does. That does. And sometimes the officers are poorly positioned to be able to handle some of these situations because obviously they're going in blind to a lot of it. Let me share real quick with you a couple of things that I saw at 2 different hospitals in the last 4 months. Nobody's getting named here on this. At one hospital, there was a emergency room incident where the guy came running out of his room, very angry, very upset, pulling stuff off of him. He's barefoot. Doctors, nurses following. They go to the outside little area. Everyone in emergency is watching this thing. Apparently, he was labeled a mental health issue, and he wasn't. He was just hurt, a lot of pain. He'd been there like 5-6 hours. And that comment kind of set him over the top. And it looked like they were starting to get the thing calmed down a little bit. And here came security, 2 really big guys in uniform. And as soon as they stepped in, it was command and control, and that thing started escalating again. Now, it got taken care of, finally. The other incident, another hospital, same type of thing started happening. There were a lot of verbal abuse going on. There were a lot of threats happening between some folks in the ER. Patients were starting to back off to different walls. Nurses were getting really cautious. And in walks one really young guy. I thought he was like 18. And he walks in and walks right straight to the one agitator, talks so low you really can't hear what they're saying. But almost immediately, this person starts going down and starts saying, I'm sorry, I apologize. That was wrong, you're right. Then he goes to the other person, same thing happens. So I chased this young guy out to the hallway and introduced myself, tell him what we do, and asked him, I said, wow, that was really good. Was that your de-escalation training kicking in? And the guy just chuckling, he goes, no, I haven't gotten to that yet. I've just been on the job like 3 weeks. His response was, when I said, well, where'd you learn to do that? And he said, customer service and retail. He goes, that's when I was going through college. We had people wanting to burn down the store and shoot people because of issues. I just treated them like we would have a pissed off customer. Which I thought was kind of interesting thing that happened there. And how would you guys view something like that?
Hi, this is Larissa. And I am at a health clinic and not hospital, but one of our reception desks we hired from Starbucks, and she had fabulous de-escalation training, like someone showing up, an hour late for their appointment and being told, I'm sorry, you can't be seen today, and them losing it. But she goes, oh yeah, I dealt with this all the time in retail. And so it was a big light bulb for me in looking at new hires to find someone who had been in contentious retail, when someone's complaining that their latte was not latte or whatever they're supposed to be.
Yeah. Well, that may be something to talk about at the next time, just customer service skills and whatnot. Dennis, are you back with us?
100%, John. Can you hear me?
I can, my friend. Okay, here we go to the next slide. Can you see it?
Of course, I sure can. And when you look at this, and I'm sure everyone's seeing it as well, that 96% is just a staggering number that healthcare workers. And so when you look at it, it also says 2 nurses are assaulted on average per hour. That's pretty scary, John. Just the numbers along tell the story. Hearing from Roy and Shane and others on the call, you mentioned something about how often are these things happening. And so that percentage is probably scary. And I can only imagine if I was a nurse going into this field, would I want to keep doing nursing if this is what I'm up against? Are they getting that when they're going through nursing school? Did they sign up to be spit on or hit or kicked? Or I don't think so. And so, I've been in healthcare for 25 years, and when I first started a workplace violence event, it seemed like the whole hospital just stopped. It was stopped. Everyone couldn't understand what was going on, what was wrong with that situation. Now, complete polar opposite. It's a daily, hourly event, depending on your community. We all have CAPRA scores for where we are. And whenever you're 3, 4, 5, 6 times the national average, your community is bringing that in, and so here our nurses are getting, an experience that they didn't sign up for, John. It's pretty alarming.
Well, let me ask this. Is there a reason that nurses are targeted so much more than others? What would be the most common reasons you think nurses are targeted more?
Well, that's a great question for the audience. Anyone want to bring that forward? I think from what I see and hear, this is strictly from the administrative side. I mean, they're the care providers for the patients. So they're the ones that are in the rooms checking vitals. They're in there getting their food orders. They're in there taking care of the patients. And so how much time are they spending with others that are techs or other people? And they're the main persons giving the care to the patient. So they are high volume related to that contact. I know physicians also, but this is healthcare workers in general. Are you guys that are on the call, you're seeing the same thing?
I think nurses are seen as a leader and as someone who's in authority, but aren't necessarily the top of the line authority. They aren't, the management. And so when you're going to be taking it out on someone that you see as middle management, that's who the person is. When you ask for your healthcare assistant, I want to talk to a supervisor. It's usually the nurse, I think, that's brought in. And so I think they often end up taking the brunt of it. At least we see that in our health centers.
Yeah, I would agree.
I would also
as well.
I would also flip it a little bit and say that it's like a predator and prey situation where a lot of nurses believe that the abuse, it's part of their job. So they kind of demur a little bit and accept it. And once the patient sees that crack, they'll exploit it and just go after it.
Yeah, I think our nurses are definitely the face of the care. It's the one they're spending the most time with them. But I also have seen that our nurses are also as not well prepared to see the signals of an assault coming because they're so focused on giving care that they don't see or hear, something is about to happen to them. All they're focused on is, for whatever reason, they just want to make sure they get the job done and get out of there. But the reality is they're stepping into a situation. They have to be aware of it. Oh, I'm sorry. Yeah, I think a lot of times they miss the signals.
Checking with Bob because if he
I would agree with everything that everybody said. In addition to, and I'm sorry, I might add it and say it because I know that we all think it sometimes. Sometimes nurses may, just because of their demeanor and how they treat people and how they may be fed up with their job, sometimes they agitate things to happen also. So I'm not saying it's a large percentage of it, but we cannot ignore that happens sometimes also. So to me, I think it's a combination of everything. I think that, once again, like everybody said, that a lot of people said that customer service is something that's learned in one section of the industry, but not taught so much in ours. And that's where we kind of fail in healthcare because we don't have that types of training. I know sometimes in some of the medical schools, they're starting to try and teach it to the physicians. I'm not so much sure on the nursing staff. I think they get a little bit, at least at the places that I work, at the colleges and universities I was at. But it wasn't something that was wholeheartedly taught or accepted.
That's interesting that you say that. Oftentimes, you're taught by training that someone is either a perp or a victim, forgetting that they're actually a person before they're that. And sometimes it's that perspective change that says, okay, I'm dealing with a person who's also a customer before they're a perp or before they're a victim. We tend to look at it sometimes through perspectives that can promote bias, if you will. And that bias can promote then the way we behave towards them. I've seen that certainly in a lot of different arenas where I've been at. So maybe that's something to talk about as well on that. Let me, these are factors that can increase behavioral escalation that came out of that meeting. Patients with pain, patients and visitors facing the fear of the unknown, long wait times. We know there's a lot of that in healthcare, obviously. Substance abuse problems, psychological problems, and patients in custody of domestic levy. So this is, as it says there, the list isn't exhaustive, but it does describe problems that a lot of employees and security departments face on a daily basis. What would you guys comment on these?
So John, you bring up a good point, and I'm sure there's more people that want to respond, but the graphic alone just is like a snapshot, right? And so what's interesting about it, and when I first saw it, was that all these items come together and they funnel, they bottleneck. It's a choke point. And so that escalation happens all the time. I know we all have our own story, right? We don't know what the other person's story is. So, you've heard different people say, walk a mile in my shoes, or put yourself in their situation. And so while these are factors, there's some people that are just unruly, period. And they want to get in front of the line. And I always joke, when you go to a restaurant, you don't get mad at the chef because you don't want them to spit in your food, right? I don't understand how people come into a hospital, get mad at the care that they're getting, and they're somehow going to get better. And it's sad because we're in pain, or they have fear, or they have all these different categories. If we could be intentional, most organizations have de-escalation programs. They also have the ability to be humanistic in their interactions with patients. But I think you made a great point earlier, a perp versus a victim. We tend to lose, we're all in this together, right? And so how do we personalize it to make the patient have less fear or reduce these escalation opportunities? And how do we do that? But these are great points that you show there. Who else has some other thoughts related to this?
So I want to talk about something that's probably outside of our space. I think healthcare is at the forefront of a perfect storm, and this storm has been brewing since about 2008. So I remember doing a presentation as a police officer in about 2006, 2008 about the future of policing, and we talked about the increase in violence. We talked about the increase in mental health issues. And we talked about the lack of resilience in society. So I think people are, I don't know, I'm getting a lot of feedback. Is that on my end or?
No, I think everyone should probably try to mute if you're not speaking.
So what we're faced with is a general population that is a lot less resilient. They don't accept things as they don't accept as much anymore. They're a lot less resilient. We're seeing a lot more mental illness out there, people who are untreated mentally ill. And then violence is the first solution for a lot of individuals because they're exposed to so much violence in social media and in the world generally. So they think that level of violence is acceptable. And they bring that to the inside of the healthcare facility where we're trying to help them, where the people who are trying to help them the most, they're bringing the most violence to the situation, and as the only solution that they think is acceptable out there. So I just think we're inside of a vacuum. Yeah, all these things that you're talking about, yes, that I would think they are factors, but I think healthcare just exists in this huge vacuum where society has changed so much. People are a lot less resilient. Violence is the first choice, and there's a lot of people out there who are who need mental health services and medication are not getting it. So that's my opinion.
Anybody else have a comment on that? I think you bring up an interesting point that you're right. Customer service, there is obviously a place for customer service and for nicer behavior or more empathetic behavior, if you will. Although I have to tell you that I did see one nurse who had a patient that was getting out of control, and she just turned around and pointed right at his face and said, "Sit down and be quiet now, behave." And amazingly, the guy just sat down and just kind of looked sheepishly at her and said, "Okay, sorry." So it's not necessarily always an either or, but maybe a both and finding the balance between that. And what do you think, since we're on this, how does security work with the nurses and doctors as a team to be able to manage these type of issues that happen? Are you finding that you're being able to work together as a team, or is it kind of everybody's having their own perspective and opinion?
I think it's a little bit of both. Often we see where the nurses think, the security or police department needs to handle a situation. And on the opposite end, from a police or security perspective, it's like, no, that's a medical issue. You guys have certain procedures and processes that's not police related or maybe security related, and you need to do your part, which then that creates a bigger issue because it becomes a us versus them situation.
Yeah.
And so it's it's a difficult battle to not to win, because if one side wins, the other side loses, and at the end of the day, we both lose. So, creating some type of multidisciplinary team that had the right people on board to discuss, these situations and learn from these situations is very crucial.
Yeah, it's very good. All right. Dennis?
Thank you, John. And, as you talked about the behavioral health risk factors, these are the ones that are patient related. So we talked about behavioral health just for a few moments. And then the other ones that come into play are drug abuse situations. And so I know more and more emergency departments are seeing that happen as it's related to patients, right? And then we talk about the demographics. So the demographics vary based on age, based on travel, based on our community. Some of us probably have rural hospitals in those communities, and people travel long distances. Some of us are more in that inner city setting where we see transportation on the public side moving lots of people throughout the city. So, all of these have different risk factors presented to the hospitals. And so by those that are on the call today, are you seeing that these each have a variable of the incidents for your location? Are you seeing impact from these more of another versus what's there today? Anything different?
One of the things that I've heard from folks, and I heard a lot about this at the AC&E, was that a lot of security officers felt unprepared about behavioral health, not necessarily knowing how to read it and whether it was something that they really wanted to manage on that. So I don't know if that resonates with anyone, but that's the one that I had heard the most from folks that I've talked about when we've talked about some of this, is that the behavioral health issues are a tough one for security officers to try to handle. Any thoughts on that?
Yeah, the behavioral health one is always, I think it's always going to be a tough one because I mean, who has a exact training program for security to deal with behavioral health? And there's another component of behavioral health that I think we have to be aware of. In the behavioral health space, we're trying to control individuals, and a lot of times security is called to be that extra control, when in actuality, sometimes our very presence escalates situations. I don't know if you guys have found that out there, but these body-worn camera videos have been eye-opening for us and have been a really great lesson for us. Sometimes our very presence in the behavioral healthcare space escalates it, and then the attempt to try to control people is always escalates the situation. But in behavioral health, people's pinnacle seeks to control people's bodies so they can give them the help they need. And then they find us trying to have security, trying to help control the person as well. And that instantly adds for a situation where it's going to be escalated before you can get that control, right? So it's definitely a tough scenario to deal with for security officers.
Oh, yeah.
This is Sean Milligan. One of the things we've tried to do is partner with our police trainers in the area and Department of Mental Health to host some CIT training for law enforcement. In return, ask for a couple of seats in that class. We've started getting our security officers through that training, and that's helped them out a lot with the behavioral health aspect of it, because you're right, the behavioral health and then the behavioral health because of drug abuse are typically the source of what we see the most violent incidences of workplace violence. The patients that are in pain and are just overly stressed don't tend to get as violent in general.
Any thoughts on the demographics? Areas of the city, areas of the state?
Hey, John, I just want to, while we have this dialogue, I think what's interesting at times, you'll see, and we've heard, hey, nursing created the situation, and then security gets called in, right, to diffuse. And then we've also heard today, and probably other comments, that security, the uniform, escalates the situation, and now someone else needs to diffuse it. So, it's one of those, how we balance that, and we hear different parts, right? We've heard in uniform, if this nurse just did this, everything would have been okay. And they've also heard the other flip side, that from the patient, hey, why'd you call security on me? I'm just trying to communicate. So now we add the, when we talk about demographics, and our slide deck today isn't all inclusive, but the diversity of our population continues to expand. And I think someone said that there's not a cookie cutter or one solution for everyone, but we have to be, to use the wrong word is always what we do. So we want to adjust, we want to transform, we want to be flexible to all those variables, where we try to get the lowest level with the lowest level of impact and coercion with the highest agreement from these diverse populations. So I think everyone gets to see it from one side versus another. But as long as we have these conversations and we have the dialogue, we can figure out what works for us, right? And so we use quality as our measurement. We're always trying to improve what we do. And if we get stuck in our ways, we'll never improve or get better. But we recognize this violence is continuing, it's escalating, and how do we mitigate that with each encounter? And so, the other comment, I know working with our team here at my hospital, we have a variety of experience between security, military, law enforcement, and regular officers that have never worked in healthcare. And actually, sometimes they are the best ones. So you have a clean slate to train with, and you don't have to cut out bad habits, right? I'm going down another trail, but related to what the topics we have in front of us, it's constantly changing. Your head's on a swivel, and you're trying to come in work that you're safe, and you go home. being safe. And so these are great points, John. Want to keep us on track for our slide deck as we keep moving forward.
All right, let's move to the next one here. Environmental risk factors. Survey of 2,500 nurses found that 48% of respondents experienced an increase in workplace violence between 21 and 22. I think we already knew that it was going up, but now there's the cost of violence in healthcare. A medium-sized hospital can experience $5.2 to $8.1 million in turnover. And it's got a nurse there, and obviously that's one of the biggest factors we've got right now. Is the lack of nursing and medical workforce. I will tell you that from a Homeland Security perspective, that one of the things that we see as part of critical infrastructure, a security gap, is the lack of workforce. American Hospital Association, Texas Hospital will back that up, is that the lot of folks walking off the job and having a hard time getting those people back. And of course, with a minimized workforce, that puts a much larger burden on the existing workforce. And that can lead to all sorts of traumatic stress, disorder, anxiety, and depression.
Hey, John, no. just one last thing on the slide, right before you move to that next one. Want to just present the question back to the group. You know, I know we're talking about health workers, and really healthcare workers in general, or everyone working in hospitals, right? So are some of you seeing this traumatic stress or anxiety from your security teams or your police teams? You guys seeing any of that stuff that's going on? So with that, John, just anyone out there that wants to answer, break in at any moment. You know, if you're not checking in with your teams, you're not doing rounding, you're not doing well-being checks, we should be doing that. You know, we're always seen as authority and we can handle this, right? But everyone's at a different level of their capacity. They had enough of this. I know that during COVID, just a quick comment, I had security officers that didn't want to be a part of that because they didn't know what they didn't know, right? So we had people leaving the field. This is on the whole other spectrum, post-COVID, workplace violence, and even our response teams are probably dealing with this stress and anxiety. Anyone else have any comments?
You know, something else that's come up through COVID and doing more telehealth is for our physicians, as well as nurse practitioners, is we are getting more threats through electronic medical records that make it more difficult to discontinue services or actually deal one-on-one with a patient. And some of those threats are against the entire clinic. And so instead of one or two people being anxious about it or post-traumatic stress over something, you have 8 or 9 people in a health center because this patient has threatened to burn it down or bomb it.
So Susan, do you see that by it being over the telephone is more of it boasts their ability to try to act differently compared to being in person? What are your thoughts? So, John, what do we have on the horizon for us? I know that we've got just around 10 minutes on our call for today.
All right, so what we're going to be doing is we're setting the stage for when Eric comes back for the next round of this particular thing. This is the first round of this topic. We're going to be looking at positive momentum for countering workplace violence. There's the new JCS standards, the new Joint Commission standards, rather. The Workplace Violence Prevention Committees, obviously, we've got SB 240 that was passed into law September 1st of this year. and will be fully enforceable by next September. So obviously a lot of workplace violence committees in place, trying to make sure that facilities are up to par on that. State associations, threat assessment teams, behavioral response teams, emergency response teams. There's a lot that's happening there. The TJC requirements for addressing workplace violence. You can see here some of these: developing the prevention systems, defining workplace violence. That's probably an important one. There does not oftentimes seem to be a common lexicon that everyone is using. Sometimes the definitions get blurred because they're not across the board with every facility or group. Establishing leadership oversight for the program, fine-tuning policies, procedures, creating easy and accessible reporting systems, analyzing, tracking, and trending data, crafting post-incident strategies, and staff training and education to increase or to decrease workplace violence. Any thoughts on this particular one and what you see are the most important ones?
Hey, John.
Go ahead.
We've got a great amount of topics that we've covered so far, and looking at this, I think the one of all of these, while this is from Joint Commission itself, when you look at analyzing, tracking, and trending data right there at the bottom, I think that every healthcare organization is tracking and trending different data. So IHSS has created a data warehouse. It still hasn't been officially released and open to all the members. I know it's still a work in progress, and you can only imagine that so much is going on to find out what is the right data to be tracked, what should be tracked, because we do so much on the day-to-day operational side. We want to make sure it's credible information and we can be impactful, And so the next part of this, John, when the Joint Commission or CMS or your state agencies, they're going to look at this and determine, okay, now that you have these programs in place, what's the efficacy? So OSHA, Texas Hospital Association, all those different ones that are coming forward are really going to put pressure on us that we can do all this, but is it really effective? And then, like everything else through quality, you plan, do, check, act, right? So you go full circle to look for improvements, you look for deliverables, and you try to make a change. And so
Yep. No, I agree. You still there, Dennis?
Someone just muted me. So, but yeah, I'm good, John. So anything else for anybody else?
The one that stands out to me that I'll throw out there is the training education to decrease workplace violence. And you notice that doesn't talk about de-escalation. When you get to de-escalation, you already got a problem. So maybe part of this is trying to find ways to not to get to escalation in the first place. And one of the things that we're working on right now with IHSS and others is to try and find a way to bring some of that training and education to both security and clinicians at the same time, to maybe train together so they work together, as maybe a topic of discussion for how we put this together. Then protecting your facilities, and we can run a few minutes over if somebody wants to. The prevention strategies, you've got security officers, video surveillance, and de-escalation training. Along with de-escalation training, I would put in there violence prevention training. And I think somebody's talking on the phone there. It's throwing it off just a little bit. Thank you. And then protecting your facilities, reporting mechanisms, education training, developing a culture of safety and respect, and collaboration with local law enforcement. Any thoughts on these last two slides?
Hey everybody, this is Simon Flores from the Harris Health System. And there is something that I'm working on here at Harris Health, and where healthcare is heading is an aspect of healthcare that I'm concerned with, and that's healthcare at home. And we are doing healthcare at home now, where our providers go into the home. And so they're seeing patients in the home. We've had a couple of incidents now where the patients are fine, but someone who happens to be there, like a son or a daughter who is on drugs, are demanding prescriptions for narcotics, and that puts the healthcare worker, nurses and doctors, in a compromising position, and you're in someone's home, so you don't have security with you. And I think that that is going to be something that we, as healthcare security professionals, start seeing, because I'm also working on a hospital at home. So if you have some minor hospital procedure, doctors and nurses will be coming to your house to see you and treat you. And so I think that we probably need to look at that and incorporate that with that education and training. It's not just hospital and healthcare facilities and clinics where at the last resort you can call security or police for backup when things turn south, because you have nobody to call when you are in their home. And so I do think it's something I would like everyone to look at. That's my add to this.
And you know, Simon, those are great points.
I think that's a good that's a good add. We're seeing a lot more of that as patients are being, one of the things trends we've seen is that as hospital beds become scarcer, if you will, patients are being moved out a little faster to go home. They're being released to go home faster, or just getting treated and moved out immediately the same day. So you're seeing a lot more of the go home. We will assign a nurse to you for the next week or two. Every couple of days they'll come by and check on you. That is becoming much more prevalent. So thank you for that. All right. Any other comments or questions before we let you folks go? We want to be respectful of that hour. All right. There's Eric's information on that. And we will come and stop sharing here. All right, so we will go ahead and send out for January's session that we'll have. That'll be the follow-up to this one, the second part of this one. And Eric has promised that he will absolutely be at that one with us. And we are going to want to solicit your input on how we can help support this by additional training, education, resources, and what we can do as a community to better manage and handle this crisis that is in healthcare right now. Any further comments? And by the way, we will email to all of you the link so that you can get not just the presentation from today, but you can actually get Eric's research that he performed for the Institute. And you'll find that is a very comprehensive deep dive on a lot of this. Any further comments, Dennis?
Well, I think today's been great, John. I think, our last one, we had a great group to participate and give us more information, highlighting the diversity of our security teams, police teams. They're all working to make our environment safer, and I'll just chime off of what Simon mentioned, that the home health could very well be another topic. So this series of workplace violence could extend to some other ones. And we'd love to hear from you in the chat. We'd love to hear from you via email. Anything else we can do to bring information to you that helps you provide safer environments, and this moves everyone further. So, John, I appreciate your moderating today and getting us to where we are right now.
Thank you, Dennis, for your partnership and friendship. And thank you all so much for coming. We are grateful to you. And we will be in touch shortly. Thank you, and have a great Thanksgiving.